Good evening, everyone, and thanks for joining us. My name is David. I'm the business manager here at AZRMC. Today, we really want to talk to you about an exciting new opportunity that we are currently considering, and that is a diabetic and wound care clinic to serve this population. So the purpose of why we want to go out into the community and start a diabetic wound care clinic is really to provide convenient, affordable, timely care to individuals managing their diabetes and wounds related to diabetes, and to be more efficiently utilizing AZRMC's limited resources to provide the best care possible. That's our purpose. So some of the advantages and why we think AZRMC is so well positioned to serve this population in an outpatient setting is that we would have an efficient use of our hospital resources. Instead of using inpatient beds, we had hoped to use preventative measures to serve our patients in an outpatient setting. This would reduce our readmission rates of patients that come back with complications due to not being able to comply with their treatment protocols. It would also allow us to really give them preventative care and services so that instead of just being a kind of emergency triage for them to come in when something is going wrong, we can be there every step of the way to really help guide them in their process of managing their chronic diabetes illness. It'll also provide an additional revenue stream to AZRMC and also give us a foothold in the community to really outreach to the community and serve their diabetic needs, but also allow our brand to grow in the community so that when they do have any other healthcare needs, they may turn to AZRMC. Some of the disadvantages, however, though, are that the initial startup costs to start any healthcare related entity can be high at times, and the regulatory boundaries that you have to go through can be difficult. Also, the limited scope of care that an outpatient clinic has compared to an inpatient facility is different. A scarcity of APRNs and those trained in diabetes management and care could also be a disadvantage. That's difficult sometimes to attract that sort of talent to a clinic. And also, one of the worries that we do come across in terms of disadvantages that maybe it could potentially cannibalize our revenue from the main hospital. This is a very small potential, but that could be a disadvantage of it as well. All right, so going forward though, we've kind of broken down our clinical implementation timeline based off the quarters of the year. So with quarter one, what we'd be really doing is we'd be really focusing on the patients that AZRMC has already served, those who are familiar with our healthcare system. What we'd be doing at this time is we would be using our RN that we'd be employing part-time at the wound care clinic to really start reaching out to the case managers at the hospital to see what cases and patients they can refer to us that would really benefit from this. Due to AZRMC's relationship to this clinic and them offering $200,000 in startup cost seed money, the clinic would be able to be fully staffed in quarter one, which would allow for this extra flexibility in usage of the staff's times due to the limited census during quarter one, which would be the first 3 months of the year. Following that in quarter two, though, we'd really be starting to focus on weekly workshops. And these weekly workshops, we'd be reaching out to the community, we'd be advertising within the community and saying, this is a great place where you can come and learn a little bit about your health. It doesn't even need to be about diabetes. It could be about healthy eating. It could just be a way to get community members in the door so that they can see what we have to offer. Because a lot of these community members, they might come in for a workshop, and personally, they might not have diabetes, but just knowing the population in the area, they may have a father, an uncle, a mother, a sister who could desperately need our services, which is why that would be so important during Q2. We would be really reaching out to that population. During quarter three, though, however, we're kind of getting the ball rolling. This is starting month 7 now. So after that first 6 months, we're hoping to have good data in terms of what we have to offer in terms of A1C management, also readmission rates. What we can do with that data is really parlay it into our marketing efforts towards other hospitals. Because at this point, we can say, we can hopefully reduce your readmission rates, which inadvertently would increase their reimbursement rates. So that's one way that we would then focus on reaching out towards other hospital chains in order to get that patient population to help them with their preventive care as well. And then with quarter four, right then we're really figuring out how we're managing the workflow and billing of the clinic. But then we're starting to focus on what additional services are our patients asking for? What type of things do they feel like they could benefit from? And we're also looking at maybe where there could be potential secondary site as well and home health services. So that's what Q4 would then really be looking at. So that's what our first year implementation timeline would be composed of. From there, though, we do look at our wages and related expenses because starting a clinic is expensive, and as with any entity, healthcare entity especially, our staff is what can really raise the price of the cost of the health clinic. So what we'd be doing is we're having a supervising physician on a very limited role, primarily because in California they are required to supervise nurse practitioners. So our nurse practitioner would be kind of the head clinician within the clinic on a day-to-day basis. Then we'd have an RN who would be part-time, 20 hours a week. They'd be teaching a lot of the educational courses as well as doing initial wound care assessment. And then the LVN who we have hired on full-time would then be doing the ongoing maintenance of the wound care. And then we'd also have a secretary. As you can see, due to that $200,000 seed money, we are able to stay fully staffed the whole year at about $22,000 a month in expenses. With employee benefits on top of that, we save a little bit with the RN being part-time, but we're still looking at about $3,200 a month for employee benefits, which include our payroll taxes as well as health insurance for employees. So from there, we also have other expenses. These would be related to medical supplies and office supplies, professional service, and marketing expenses. Some of these items are just fixed costs, depending on, it doesn't really relate to how much revenue we bring in. It's just related to running a business. So that's our professional services and marketing services. Those aren't going to change if we have one patient or 100 patients. Those are fixed. And so throughout the year, those remain the same. Our medical supplies and office supplies, however, do correlate to how many patients we have. And as you can see, they do trend up slightly throughout the year as our census grows. And then with capital purchases, due to the limited scope of care that we would be providing at an outpatient clinic, we really are going with the basics in an ECG machine. We would be having a treadmill, IT software upgrade, which would primarily be Epic Management, which is what the main hospital uses now. And then also our IT hardware upgrade would be about $4,000 for 3 computer workstations. With that being said, all of these capital purchases would be being depreciated with their generally accepted accounting practice lives of 5 years for the ECG machine, 5 years for the treadmill machine, 3 years for the software upgrade, and 5 years for the IT hardware upgrade. So our depreciation expense throughout the year would remain consistent. And in conjunction with our other expenses, we're looking at about $32,000 a year total expenses, generating up to about $34,000 at the end of the year, for a total of around $400,000 a year of expenses. So anticipated revenue, as you can see, our top line item is that $200,000 amortized over 12 years. What we're going to be doing with that is it's really going to help bolster our bottom line in the beginning. From there, though, we are going to be anticipating Medicare revenue for our specified patients and the services rendered to them, as well as Medicaid. And then also we would be serving patients who are self-pay. So those are kind of the 3 main areas, as well as private insurance. But for this pro forma, we're looking at those 3 main revenue sources, in addition to the $200,000 that's amortized from the seed money of AZRMC. Excuse me. So at the end of the year, we're looking at right around $520,000 of revenue. All right, so now the fun part, our year 1 projected financial results. Once again, these are projected results, but you can see quarter 1, which is July through September, we are in the red. We are losing about $3,500 a month. Starting up in quarter 2 and onward, we're beginning to kind of pull out of that, and we are starting to make a profit. However, going back to what we had said about that seed money from AZRMC, that is about $16,000 a month that we are taking in. So quarter 2, if that money was not there, would also be showing a loss. But because it is there, we are showing a slight net income. But then going forward from Q3 onward, the numbers start to really improve once the census improves. The revenue is really tied, what we were doing is really tied to the growth of the clinic, with about 30 to 40% caseload at the beginning, Q1, and then it kind of gradually increasing throughout the year, which is why we're having that increase in income throughout the year. It's just based off of um, public awareness of the clinic, as well as a higher level of established patients that we can use with not use, but that we can that we have on our census. All right, so some of the desired outcomes and community benefits of a clinic like this. One of the outcomes really is the efficient use of hospital resources. As I'm sure you guys are all aware, and why we are doing this virtually is, with the coronavirus going on, inpatient beds are an all-time in-demand need, and that's changed a little bit with this virus going around, but it's always the way it is that inpatient beds are sometimes hard to find, and so how if we can utilize our resources to provide better outpatient care to where we keep those patients out of an inpatient setting, we can better and more efficiently use our hospital resources. It's also going to reduce our admission rates. When we went back to that financial budget, we didn't even look at what the indirect savings of reduced readmissions rates are to the organization in a whole. So that's another thing. Preventative care and services is another outcome that we hope to see in lower A1Cs and lower readmission rates. And then the additional revenue stream, of course, is a desired outcome that we have for sure. And then that community outreach where patients have AZRMC front and center in their mind when they think of the needs that they have as healthcare. In terms of the community benefit, what we want to really do is improve the access to care. That's a community benefit. We want to improve patient outcomes. That's a community benefit. There's even the employment opportunities within the community, which is a community benefit. And then the educational resources provided in the weekly workshops is a great way for the community to really have a good benefit from having AZRMC's clinic in their neighborhood. All right, so the marketing here. Our target patient really is that 20 to 70-year-old male with diabetes or prediabetes. It's a pretty wide range in terms of the age group, just because we see diabetes affecting the whole spectrum of life these days. Our marketing phrase based off of the patients that we've spoken to is take back control and live well, because patients feel out of control. They tell us they feel like they can't manage their diabetes. They feel like they don't have the tools needed to manage their diabetes, and they feel like it runs their life. So our message to them is, let us be on your team. Let us help find a way to take back control of your management and really live well, so you can live to the fullest and a healthy life. So our marketing brochure, we chose a standard trifold brochure. What this is going to be done is it's going to be placed in primary care settings around, as well as it can be given out by the case managers. What it does is it introduces the patient to us, lets them know where we are, what we do, who we serve. It also gives us our contact information as well. From there, it goes over our philosophy that, it's a team approach, that it's an active team of nurses, nurse practitioners, doctors, who are there to really help support and manage their chronic condition of diabetes. It goes over the steps that they really come in and talk with us, that they can attend a workshop, and that from there we'll start routine monitoring and treating them. And then from there, with their tools in place, we really want our patients to feel like they can manage this diabetes, they can be successful, and they can live well. One of my favorite quotes is from one of our patients that we had been talking to at the hospital, and he says he had mentioned that his diabetes was out of control, and this is just a hypothetical that we want our patients to say, my diabetes was out of control and I didn't know what to do, but now I feel like I finally have my life back and can live well. So that's really what we're striving for here at AZRMC Diabetic and Wound Care Clinic, is we want patients to feel like they're in control of their lives, that they're in control of the management of their diseases, and that really we can be there as a team to help them move forward and live well. So if you have any questions, let's start working through them, and let's go from there. Thank you guys very much for your time.